I thought I'll talk about the pyramid of care once more, but I wanted to stress the importance of ultrasound examination in the pyramid of care, and not focusing too much on the classical idea of how the pyramid of care could be, or how the pyramid of care could be invented, but look a bit more into some weaker points where we may need to work a bit more in improve our detection rates. But let me start from the beginning. Well, if we look back for now, well, more than 20 years, first trimester screening was a simple assessment of something that is in behind the fetus here, which is called the nuclear translucency, but you can see that the resolution was so bad at this time that we were only able to say this is 1, 2, 3, 4, 5 millimeters, and we're not able to even set on decimals. But this was the first step towards a new approach in terms of a different assessment of the pregnancy and a different assessment or a different actually approach to the pregnancy and pregnancy care. And obviously this has evolved very much within the last years, and we now talk about chromosomal abnormalities, that was the basic, but about fetal defects, preeclampsia, IUGR, preterm delivery, macrosomia, gestational diabetes, and plenty of other different issues are coming to this. And that was the main issue of saying, well, maybe it's time to invent or actually invert the pyramid of care and put much more effort on the first trimester. And maybe if we put so much effort on the first trimester, and we can see that a pregnancy is a low-risk pregnancy, we may be able to reduce pregnancy care. Although I'm a bit critical about reduction of pregnancy care in a system that works quite well, but at least we can stress on the relevant issues that may come up in the course of the pregnancy. So this was the basic idea of the inversion of the pyramid of care. And if we look to the detection rates that can be achieved by the first trimester, well, then we know that screening for chromosomal abnormalities as the classical issue of first trimester screening, we've got now detection rates of more than 99% with cell-free DNA screening, which could be just part of these first trimester screening approach for a false positive rate of, you see, 1 to 5%. Yeah, well, we'll talk about cell-free DNA screening in a second. You'd say, well, but it's just 0.1%. Why is there 1 to 5%? There are always these 1, 2% with missing, with informative results. So the false positive rate may be sort of 1, 2, 3, 4, 5%. Then we've got screening for preeclampsia with detection rates of more than 90%. We've got IUGR, which doesn't work as good, but similarly good. Preterm delivery, gestational diabetes. So a lot of issues there, which actually stresses the importance of first trimester screening. If we go a bit more into details in terms of screening for chromosomal abnormalities, then for me it's obvious that this is the way we will go for. Cell-free DNA testing, if we look to the very recent result of the meta-analysis of Professor Nicolaides and his group, then you'll find detection rates for trisomy 21 of by far more than 99%. And that recent review was for 99.7% for a false positive rate of 0.04%. So this is impressively good. And even the other chromosomal abnormalities, trisomy 18, trisomy 13, which were always a bit weaker than the trisomy 21 issue, well, they are extremely good as well. And even Turner syndrome has improved, and it's now 96% detection rates. So the big question is now, how can we implement it into a routine screening, and how shall we combine it with sort of first trimester combined screening, sort of ultrasound examination? Well, if we just look to trisomy 21, well, then it would be obvious. Then we only go for cell-free DNA testing. But there are by far more problems than just trisomy 21 or just the common chromosomal abnormalities like trisomy 13, 18, and 21. There are the issues of cost that are still unsolved. There are issues of infrastructure. And there are those previously mentioned 2% failure rates, where we still don't know what to do with those ones where we go for invasive testing, where we go for detailed ultrasound examination. So for me, for now, at least, I think for the next 10 years, it's not whether we do ultrasound or cell-free DNA testing or combined screening or cell-free DNA testing, but ultrasound and cell-free DNA testing. And that will be the way it will continue. And the big question now is, how shall we combine these two issues? And at least for now, it's mainly an issue of costs. And I think the most reasonable way to go for is to say, well, we'll do the basic and very, very good first semester combined test based on the ultrasound examination of the nuchal, maybe with the additional markers, together with serum biochemistry. And if we do have a high-risk result, we still go for invasive testing. And if it's when it's a low-risk result, we leave it there. And only if we are somewhere in between, and we can discuss the cutoffs, but if we are somewhere in between, then we're not going to carry on with nose bone, ductus, tricuspid, etc. But that's the place where cell-free DNA is worth to go for. An alternative approach would be to say, well, we only concentrate on the ultrasound examination, and if there is a major defect or if the nucleus is increased, we leave it there and we go for invasive testing, because again, there are many more defects, many more chromosomal abnormalities than just trisomy 21 in this group, and it's better to go for invasive testing in this small group. But if everything looks normal, then the risk for a lot of chromosomal abnormalities is already still low, and we'll then carry on with cell-free DNA testing in this group, and we could actually increase the detection rate for most chromosomal abnormalities, and especially for trisomy 21, to that level of 99-point-something%. But at the same time, when we draw blood for cell-free DNA testing, we actually draw another blood sample, and we'll keep it behind and may do PRGF, for example. But if we are not able to get a result with cell-free DNA testing, then we carry on with classical combined screening, and that sorts out the problem that 1-3% of informative or test failures, and it will get a result to those patients, and they will not go into invasive testing, which is proposed by other study groups. So I think this issue is done, and it's only fine-tuning how these different elements can be combined. And the next big approach that's been, from my point of view, it's also been sorted out, is screening for preeclampsia. We know that there are very good screening programs that combine the history of a patient, that looks to the uterine artery Dopplers, that looks to the blood pressure, and that looks to PRGF and PAP-A. And in combining those different parameters, the detection rates are impressively good. They reach about 80% for preeclampsia of less than 37 weeks. And if we go a bit more into details of those ones, they run into preeclampsia of less than 34 weeks. Detection rates are even higher and go above 90%. The big issue here was whether it's worth screening for preeclampsia if there is no real prevention of preeclampsia. But I know Leona will talk about this issue tomorrow, so that I'll stop here and will only mention that yes, aspirin works, and because it works, it's also worth going for a screening program for preeclampsia, because we do have a prevention system. So all of these issues are, from my point of view, well sorted out. I think there's a third issue which we could work a bit more on it, and these are fetal defects. Because detection rates are just 50%. And here, if we look to the prevalence of fetal defects, well, then this issue is of importance. Let's go to this paper of Sungulaki from the Nikolaidis group. And in a very large study group of 45,000 patients, they had a good follow-up and looked for fetal defects and the prevalence of fetal defects and compared them with chromosomal abnormalities. And as you can see here, fetal defects were found in 488 of those 45,000 cases with a prevalence of 1.1%, and was even higher the prevalence than the prevalence of chromosomal abnormalities, which was 0.7%. So this stresses the importance of go a bit more into detail in these in terms of fetal defects, and check whether we may be able to improve the detection rates of these major defects. And even in such a study group where first trimester screening has carries such a big importance, the detection rate was just a bit more than 40%. And the main time of screening for the main time of detection of major defects was in the second trimester. Now, if we go a bit more into a standardized a way of getting to the first trimester anomaly scan, which was a consequence of those low detection rates. This was done by the ISWOG and also by the German Degum Society. Different groups have started to set up a list of things that should be seen in the first trimester in order to, well, standardize the first trimester anomaly scan, and in the hope that we may be able to increase detection rate of major defects. And just an example from the ISWOG Society, the list of anomalies, well then, yeah, well you can see it's quite, the list of structures that could be or that should be examined is quite long. And even though you may not be able to read this list, I can go with you through the pictures that are necessary to fulfill the criteria of the ISWOG. It's the head of the baby with the skull and the butterfly sign of the plexus. It's the profile in different sections. It's the eyes, and you can see both eyes together with the lenses here quite well. It's the lips and the retronasal triangle to detect facial cleft lip, cleft palate, and cleft lip. Here would be the lips. It's the profile itself to detect retrognathia. It's the spine. And obviously, if we talk about the spine, we also talk about the posterior fossa to detect spinal defects in the first trimester. It's the heart of the baby, together with the Doppler blood flow mode and the 3-vessel view. And of course, again, it's the tricuspid blood flow and the ductus venosus blood flow, which may be helpful to detect cardiac defects. We'll come back to that in a sec. It's the diaphragm on one side and on the other side. It's the abdomen with the stomach. It's the 2 umbilical arteries and the bladder in between, the 2 kidneys, and the insertion of the umbilical cord, the feet and the hands, and obviously, and the fingers, and the placenta that should always be seen in the first trimester. This long list of things, this is very ambitious and difficult to get it properly all the time, but that's the list that ISWOG has set, and it remembers, or it looks like a second trimester list of things that should be identified. So that is at least the approach the ISWOG Society took. Now, if we go to review papers again and look to the overall detection rates of major defects, it hardly exceeds 50%. So, and that's the big issue here. Why it's just 50%, and why don't we get up to 90% or at least 80% with, like we did with chromosomal abnormalities or with preeclampsia? Well, that's the big issue that we need to ask ourselves. Which defect should always be detected in the first trimester? Which defects could be seen in the first trimester? And what can we do to improve the quality of the first trimester scan? What can we do to increase the detection rate? Let's start with the anomalies that should always be seen, and what we could call them the big 5. These are anencephaly, as we can see it here. And anencephaly is exencephaly in the first trimester. It's holobrosencephaly, as we can see here, with the monoventricle. It's gastroschisis, as we can see here, with the bowel being outside the abdomen. And it's exomphalus and obstructive uropathy, as we can see, with a megacystis of by far more than 50 centimeters. Well, why are these ones so important, and why should we see them always in the first trimester? Well, first of all, they've got a devastating outcome, like with anencephaly or holobrosencephaly. Second of all, they are associated, at least some of them are associated with other chromosomal abnormalities, and they may need a more detailed work up, and then it's easier to detect those things in the first trimester and still have a lot of time for the follow-up examinations. And thirdly, some of them are much more difficult to detect in the second or third trimester, like, for example, with small gastroschisis in a fetus that is small, with low amniotic fluid volume. It may be quite challenging and much easier to miss a gastroschisis than it is in the first trimester, where it's very easy to see. And then obviously there's a long list of things that could be seen. And just like some examples, you've got skeletal dysplasias, like here with that arm that is abnormal. Go back here. Then we've got a case here of, a case of spina bifida, some cardiac defects, some cleft lip and palate, or a diaphragmatic hernia. All of these defects may be seen, but there's no structured list of things that need to be seen. And I think always when I see those lectures, it looks for me like a nice list of things that someone has seen before, but I miss a clear structure of things that are really identifiable and other anomalies that are that cannot be identified in the first trimester. And let's try to sort these ones that we've seen here. Well, I think there's a list of anomalies that can always be detected, and these are the big five that I mentioned before. It's anencephaly, holoprosencephaly, exomphalus, gastroschisis, and megacystis. These are the easy ones, and they should be detected by everyone who's doing a first trimester scan. And then there are other anomalies that can certainly be not detected in the first trimester because they're simply not there. And this is microcephaly and other CNS defects like ventriculomegaly, at least the classical types. There are fetal tumors, lung defects, and some cardiac defects, and most of the gastrointestinal and renal defects. So these ones will be on the negative list because there's no way of identifying those defects as they're simply not there. And there are then those ones that can be potentially detected, like facial clefts, like spina bifida, some cardiac defects, renal agenesis, diaphragmatic hernia, skeletal dysplasia, just to name some of the list. And I think we can work a bit more on those ones to increase the overall detection rate and consider some other markers that may be helpful to detect those potentially detectable defects. Well, and what could we do? Well, let's talk about an improvement of the ultrasound, a technical improvement of the ultrasound examination first. And that is by just pushing the ultrasound examination away from the 11 weeks to 13 weeks, maybe even 14 weeks, but at least 13 weeks. To previous times, we were always saying, well, do the ultrasound examination, the combined test at 11, maybe 12 weeks, because the detection rate for trisomy 21 is higher at 11, 12 weeks. Nowadays, I would say, well, let's push it a bit more to the 13-week side, and we can identify by far more of the fetal structures than we can at 11 weeks, like you see in these two images of the same fetus at 11 weeks or at 13 weeks. And it's also expressed by the detection rates here of that summary paper, where it's clearly shown that if you do an anomaly scan at 11 weeks, your detection rate is about 40, a bit less, about 40%, and it increases to almost 70% as soon as you reach those 12, 13 weekest side. Okay, so that is, I think, one easy part to do. Push the first trimester scan to the larger baby side, and immediately you've got much better, a much better situation to detect major defects. And the other issue is, well, use transvaginal ultrasound examinations, especially in conditions where it is a bit more challenging to get a good image. Yeah? And just to underline this, just to stress this, these are two videos of the same patient, once been done by an ultrasound, by a transabdominal ultrasound domination, and the same fetus is being examined by a transvaginal ultrasound examination. And it's very obvious that the transvaginal approach does give you, in these situations, particularly in these situations, a much easier way of getting to the fetal structures. And in some situations, it's even easier to get good images in the first trimester where you do have the chance to go for a transvaginal approach compared to a second trimester. Again, imagine if you do that ultrasound examination in this woman, it is challenging even in the second trimester to get to appropriate images. Well, and obviously you need some experience, and it's an issue of training and training and training. As we mentioned, or as we stressed it with the nuclear transduction fee measurement. And just an example, I think this is the top end. This is a study group from Berlin, and they examined 86 major defect cardiac and non-cardiac defects, and their detection rates, they were above 80%. And this is a particularly trained group, so I don't think it can be achieved by everyone, but if you do a lot of training in this particular field, you will improve the detection rate to certainly more than 70%. But as not everyone is such a good ultrasound expert, will need to think about other ways of getting to such a better detection rate, to increase our detection rate. And I think the keys, and these are screening parameters that are easy to detect and that which then increase the risk for some major defects. And some of these ones, some of the cases may be then seen by an expert, and this kind of screening system may help to improve the detection rate. And the most simplest way would be to have some biochemical parameters that are already well known and implemented into a screening setup, and PRGF is the one that is quite promising in this situation, because there are some studies, and I just want to mention that one, that have shown that in cases with a cardiac defect, PRGF is lower than the normal population. So this may be an easy way to increase the detection rate if the PRGF levels are quite low. It's not only an issue of maybe a chromosomal abnormality or maybe preeclampsia in the subsequent course of the pregnancy, but maybe even a sign of a cardiac defect. And the second marker is alpha-fetoprotein. This is even easier because it's cheap and everywhere available. And in the studies about acrania and spina bifida are there. I think, Kevin, you published a paper where you shown the difference, that it's not working, isn't it? But at least there is a controversy, and I think this could be a marker where that could be useful in screening for neural tube defects, and maybe even for cleft lip and palate as well. But besides those biochemical markers, it's always the ultrasound examination, because you've got that tool in your hand, and it would be much easier and much cheaper to go with a detailed ultrasound examination and to have surrogate parameters that help you to detect certain fetal defects. And the most well-known and oldest marker is the nucleotranslucency. We know that it's a marker for chromosomal abnormalities, but it's also a marker for major defects if the karyotype is normal. And that's certainly for all of us the first step towards a detailed anomaly scan. If the nucleus is increased, everyone is much more worried that we'll find a major defect in the subsequent course of the pregnancy. And this is particularly true for cardiac defects, and we know that if the nucleus going up to more than, let's say, 5.5 millimeters, the risk for cardiac defect goes up to 10%. So this is particularly true for the individual risk assessment. Unfortunately, it doesn't work in screening for cardiac defects. There are plenty of studies looking to the overall detection rate with the nuclear translucency itself. And if we take the 95th centile, then we'll get to detection rates of about 30%. But for the individual risk assessment, it is of worse, and clues can be taken in terms of further examination. In order to improve the detection rate for cardiac defects, well, several studies have shown that the ductus and the tricuspid are interesting markers, and each one, so the nuchal, the ductus, and the tricuspid, they are abnormal about 1/3 of the pregnancy. In summary, if you take one of those three being abnormal, then you get to detection rates of about 60%. Unfortunately, the false positive rate is also quite high with 8%, but at least you've got a detection rate of already almost 60% without even looking in detail to the heart. So maybe with a more detailed look to the heart, detection rates can reach those 80% by having a certain hint that this baby may have a cardiac defect and needs a much more detailed examination. Let's take a different story, and this is spina bifida, and this is a very classical way of how a surrogate parameter may help to increase the detection rate. in previous studies that looked to detection rates of spina bifida in the first trimester, detection rates were just about 10 to 15%, because detection of spina bifida by just looking to the spine itself may be challenging, and it's also challenging in the second trimester. As you can see, these defects may be small, and the same way they may be difficult to identify in the first trimester. For the second trimester, it's easy because we know that there's a banana sign and there's a lemon sign. These were invented in the late 80s and that have increased the detection rate of spina bifida in the second trimester dramatically to almost 100%. Now, again, it was Professor Nicolaides and Professor Schaui from Berlin who looked a bit more into details whether there is some marker in the first trimester that may be helpful to detect spina bifida in the first trimester. And because there must be something in the brain that is abnormal, they looked to the same part of the brain, to the posterior fossa, and identified some structures that are abnormal and that are easy to identify because it's the same image as the nuclear insufficiency image. And they look to the posterior fossa here, and this is an abnormal case here, and this is a normal case. And these two pictures are different in one structure, and this is the IT, the intracranial lucency, which can be seen here, which is present in this picture here, but it's not present in this picture here. And this was the first sign of spina bifida in the first trimester. Some other groups have then carried on to look to some ratios between the brainstem and the distance between the brainstem and the occiput, and find some more markers to increase the detection rate. But at least looking to that area, which is certainly not the spine, but a surrogate parameter that may help to detect spina bifida, that was the right way to go for. And these are two other cases here, which shows you quite well the abnormality of the posterior fossa in one side, and here's the other one. And if you compare that with this picture here, where you see, to be a bit more simplified, three black areas and two white lines, you can only see, in the affected case, you can only see two black areas and one white line. And this is by far more easy, and by far easier than the detection of spina bifida itself. In this case, it is rather easy because the defect is certainly bigger, certainly large. But to be honest, this one, I would have missed this one, and I've only detected this one because I found the anomaly in the brain. And then I went on, carried on with a transvaginal ultrasound, and there I identified the spinal defect. Now, as a side effect of the well, this one what I wanted to mention, this was already proven in a nice multi-center study in Berlin, and they examined 15,000 normal pregnancies and 11 affected cases. And with these signs, and they actually didn't mention that, the study group didn't mention that one particular marker was better than the other, but just by looking to the posterior fossa, all of the 11 cases were detected or at least suspected and proven later on in pregnancy. As a side effect of looking more in detail into this, in the posterior fossa, there was this study group around Volpe et al., who also seen that in some cases the IT is even larger than it should be. Not smaller like in spina bifida, but larger. And in the follow-up examinations, they identified that most of these cases were also abnormal. They had posterior fossa abnormalities like Denny-Walker malformation. So there are several chromosomal abnormalities in this group. So in a different way, it's also helpful if the IT is massively increased rather than decreased. And obviously, you know, previously absent Denny-Walker malformation was on the list of markers that cannot be identified in the first trimester. And with some surrogate parameters like the increased IT, it opens a field where it may be able to detect at least some of the affected cases. Let's move a bit further on and go to our last point, the last example of how surrogate parameters may be helpful to increase detection rate of first trimester defects. And let's look to facial defects. And all of us well, would see this baby, and obviously the resolution is not that perfect, but the only thing you may be able to see is that the nose is a bit longer here, but otherwise it would be difficult to detect that this baby's got a cleft lip and palate. The same is true on this picture. It's very, very difficult to detect these fetuses with that facial defect. And if you look to the studies again, the detection rates, they're about 5% by just looking to the face and to try to identify facial cleft in the same way as we do it in the first trimester. And detection rate increased a bit by saying, well, let's look to the face in a different way, not just in the section where we do the nuclear translucency scan or the nuclear profile picture, but let's look to the face in a different way, to look directly to the lips. And if you do so, you can identify at least some more of these cases with cleft lip and palate, as you can see here, where you see a bilateral cleft lip and palate on those sides. And this brought up the idea of the retronasal angle, triangle, where you identify this structure here, this triangle, and if you can see it as clear as it's here, then it's very unlikely that this baby has a cleft palate. This was a step forward, but I think the breakthrough was where at least one study, and a bit of our study maybe as well, and this was a different approach to this picture. Previously, we always wanted to see the cleft lip and palate itself, but if you look to the palate, or actually to the maxilla here, okay, and you can see that cleft here, that gap in the palate, that may be a very helpful sign of identifying cleft lip and palate, because this is the bony part of the premaxilla that's been pushed upwards, and this may be a very helpful and easy sign to detect cleft lip and palate in cases where you may suspect it, but where you certainly are not able to identify the defect itself. We try to push that marker from a qualitative marker into a quantitative marker and try to measure something that makes it much easier to implement it into a screening algorithm, and we try to make it easy to draw a line between the mandibular and the maxilla, and if this line touches the frontal bone, as you can see here, then it's okay, and if that line is by far away from the frontal bone, then this is suspicious of a cleft lip and palate. And in the cases that we've examined, there were all but one of those cases with a frontal space measurement above the 95th centile or below the 5th centile. And obviously you don't need to draw that line and measure it, but if you just draw that line in mind and see where you are, it's already helpful. And believe me, we found several more cleft lip and palates by using this approach after we published our paper. Now, let me come to an end, and let me stress the importance of ultrasound examination by saying most of the information is in one particular image, and that's the nuclear translucency image. And it's not just the nuclear translucency image, it's the all-in-one profile picture. Because you've got the nucleus here, which is the first and certainly the most well-known marker for chromosomal abnormalities, and which helps you to identify, or actually to sort out which features should go into self-FLDA testing or combined testing or invasive testing. And you've got the second part of that image, which is the view to the posterior fossa, which helps you to identify spina bifida, to identify cerebellar abnormalities, at least some. And you've got that view to the frontal bone, where you may be able to identify anencephaly and holoprosencephaly. And you carry on looking to the face of the picture, and by using this marker that I've just shown you, or the gap itself, you may be able to identify facial clefts or retrognathia. Yes, so this is from our point of view, the all-in-one picture with a lot of surrogate parameters that may be helpful to detect certain fetal defects. And, well, let me thank you. And, yes.